Okay, welcome back to Montreal Heart. In this room, we have a, I think, interesting case that will bring some discussion. I'm Jean-François Tanguay. I'm working with Dr. Robert Avram, who's looking at the IVUS at this time. And we have Jimina Dulub, that's a fellow with us today. Could I have Sophie, the first slide? I'm also working with Tanya, with Ines, and with Geneviève. Thank you. That's the IVUS catheter. So, Sophie, could I have the first slide, please? Sophie? Okay. Well, I know the case, so I can give you the case, but I would like to have the slides to show you. It's a simple case, a 74-year-old man who was referred from another hospital for accelerating stable angina. Threshold was lower, and quality of life was not so good. And so he was referred to us to do a diagnostic angiogram. As comorbidity, he had no prior history of CAD. He was treated for dyslipidemia, had no history of diabetes, had the pulmonary sarcoidosis in the past that is stable, had a history of cancer, and again, was transferred for angiogram. Next one, next slide. All his labs, obviously, the troponin were negative, labs were unremarkable, and we had the angiogram done yesterday. That we will show you. Est-ce qu'on pourrait avoir l'angio d'hier, s'il vous plaît, la coronaro? So if I can have the coronary angiogram of yesterday. I must say first that the case we had planned initially was done at night on call because had chest pain and ST changes, and it was a calcified ostial right, but we won't show that for you today. It's done with a great result by my colleague, Dr. Avram. Can I have the angiogram, please, of yesterday? What you will see, once we show it to you, is that the right coronary artery has no significant disease. My colleague who performed the angiogram had, how can I say, question about the LAD lesion. I still don't see the angiogram. Mid-LAD, 50 to 60%. Proximal LAD, if I can show it to you, had a significant stenosis at the ostium. But after giving IC nitro, the LAD was not significant anymore. So that gives you one first. I mean, I always tell the fellow when we can, unless it's very severe aortic stenosis or whatever, shock patient, it's very useful to have nitro because obviously this case is very different. Now, there was also a diagonal that had the stenosis at the ostium, small in diameter, but pretty long in territory. And I still don't see the angiogram myself. Oh, so you see it there. Okay, that's interesting because I don't see it from here. But maybe you can appreciate that there was a stenosis on the circumflex that was severe. There was intermediate lesion on the LAD, diagonal at the ostium that had disease. Donc, est-ce qu'on peut me montrer, est-ce qu'on a vu toute l'angio? Est-ce que je vois pas? Vois-tu l'angio? Okay, so what we can do is, because we started, as we were waiting, we started the procedure. Do we show the FFR? I don't hear anyone, but I think we just do the case, talk, and
X.
That could explain partially or all the accelerating agenesis. In addition, you also have an intermediate lesion of the
LAD.
And also the first diagonal. Our goal today is to extend the circumflex using imaging and also interrogate the LAD.
On voit le nom. Fait que là, je pense qu'il est en train d'enlever le nom, mais je sais pas.
We're also going to perform a FARCO registration circumflex just to demonstrate the utility of different types of disease.
So do you want us to show the measurement we did of the LAD first? The circumflex. Let's go in the circumflex. Of the circumflex. Il nous va falloir stenter, à un moment donné. On a fait la vis, ça mesure combien?
3,25.
Okay. So we'll do 3.5? A trio? Okay, good. Okay, so we're just talking, sorry, it's bilingual French and English, but the patient is there on the table. He has a bit of pain. So at some point we have to take care of his circumflex, put a stent there. And we will show you at some point the IFR co-registration. When you see the angio, you can see yeah, okay, good. You can see that the lesion was severe in the circumflex. This is not a very complex lesion. After doing balloon angioplasty, we perform IVUS. So the measurement went from 3.25 to 3.5 about, maybe a bit bigger in the proximal part, 3.75. And the lesion length, we think with a stent of 18 millimeter, we'll be able to cover. Yes. So we're trying to show you the IFR pullback at this time, which we registered, and it was interesting. I mean, it showed that the lesion was quite significant. By memory, the IFR was what, 0.7, I think. And then you could see by pullback that it was really the stenosis. There was no diffuse disease versus what we'll show you in a few minutes on the LAD. For now, we're still looking for that picture of the IFR. OK. Passe-moi le stent. Ouais. Un ACT, s'il vous plaît. And then let's do the stent. ACT sur la table. OK. Stent was 0.18. That's good.
So, not surprisingly, the IFR pullback showed severe reduction of the IFR. So physiologically, IFR around 0.70 was a huge step up. Show you exactly here. You see the step up. It looks like a staircase. And you can see that the IFR normalized approximately to this lesion. For a client here, we also use the distal diameter is there are 20 segments approximate distally. The length of the lesion is around 50 millimeters. But for client here to send a slightly longer stent. So we
3.5? Yeah. Or 3.75 short non-compliant balloon. Yeah, excellent. So we'll take the Science Pro. Yeah, Trio 18 Science Pro. Huh? Yeah. Or zero?
So our excellent nurse, Ines, she's suggesting the Orsiro. Maybe you can mention like some particularities about this.
Well, I think the Orsiro from Biotronic is a very good stent. In trials, at least in MI trial, it was superior actually to the Science. But here it's not a STEMI. It has very thin struts. So the struts are 60 millimeter, micrometer. I mean, not millimeter, micrometer. So it's the thinnest strut available, at least in our market, for drug-eluting stent. So what we plan to do is put that stent, then we can post-dilate. So if it's a trio, it can go up to 3.5 without any problem. Sophie, you have something?
Nobody could hear what I said.
What do you mean?
I was disconnected.
Okay, it looks like the microphone of my colleague, Dr. Avram, who said very good things about the IFR, the co-registration, was not working. So we apologize for that technical aspect. But we will try to repeat. Now what we're working on, if you haven't heard, is on the circumflex that had a co-registration IFR, the optic cross wire from Philips that showed a step up, not surprisingly, at the stenosis there. And we will put this in contrast with the IFR co-registration we did from the LAD and the diagonal in a few minutes. Hopefully you'll hear Dr. Avram again, and I'll continue talking while they're working.
Jen, do you have the coronary co-registration image?
So what we could show again is to, do you have the co-registration, the image, the angiogram? Okay, so maybe you can appreciate now the 0.79 measurement. We did two co-registration, and both were highly significant, and the dots we're all focused on the stenosis, which is not surprising again. We use that wire because we had done it on the LAD before that we will show you after.
Just review the K. Push a bit.
Okay, let's
your
do
wire is not good
here.
now. I don't know why your wire.
So hopefully you see us work live. Putting that stent, you have the control for the contrast, Robert. Okay, so we'll put the stent exactly where we want, and then post dilate. Our plan is to go post dilate.
Unfortunately, the wire came back just a bit, so I'm just going to reposition. Sometimes, okay,
you will advance the stent a bit more.
And we have our roadmap. We have the step up of our co-registration up test.
Right.
So we want to, I want to lend it just proximal to bifurcation.
Want to do a cine just to make sure we're okay?
Cine.
Just to make sure we're perfectly okay. Like,
looks good.
Okay, looks good. Yeah, come back a little bit, but it looks good. Oh. Looks pretty good. Yeah, go on. Yeah. I think we can go up to 16. But yeah, we can go up to 16, I think.
So we measured the distal diameter around 325. I'm going to go at 16 atmospheres, which is 325. And you can see there's some dye because we did some injection at the same time. I'm going to.
Est-ce qu'on peut avoir un ballon 375, 8 mm non compliant, s'il vous plaît?
I'm also going to take a 375 balloon by 8. I'm going to post-dilate. So not a complicated PCI, but just to show you the different phenotypes of cardiovascular disease on IFR pullback. Yeah. And we'll go back to the LAD because I think that's where the interested discussion is.
Absolutely.
But first, we'll treat this lesion, which is probably the cause of the patient's symptoms. Avez-vous des douleurs dans la poitrine?
Ça va bien, monsieur. OK.
Là, ça diminue.
I'll do a cleanup.
On a débloqué, tout est beau. So now the patient chest pain is now resolved. So probably that was the one of the lesions that was contributing to his angina.
Okay, we'll go to 375.
We'll pose dilate, and then we'll do an IVUS run just to make sure that everything is well opposed and expanded. And then we'll circle back to the LAD.
Yeah. And by the way, is there some Slido question? I would like to know from Sophie, do we see the Slido? Is there any question, any comments? And for now, quite simple, but interesting physiology and imaging combination. One day we'll have catheters that will be doing both,
Perfect.
Which will be interesting.
Perfect. So you can see, so that's really a useful image. We are lucky here to have IFR co-registration available with the Philips wire. And in this case, you can see the yellow dots, areas that there is a significant variation in the IFR. And you can see the majority of the variation in the IFR here. It goes from 0.79 all the way up to 1.0 in the prox to mid circumflex, right where the lesion was. And you can see there is actually no variation of the IFR distal or proximal to that, suggesting it's a focal lesion that's amenable to PCI.
Yeah. Oh, you see it now. Okay. Can you see that? Sophie, can they see the FFR? The little yellow dots and everything? The image we have on the left bottom. Hopefully you can see that.
You can see our excellent fellow doing great work.
Yeah, Jamina, go ahead.
We're going to poise dilate the stent in the circumflex.
And we'll probably do a dry run or do a stent boost or something just to
Yeah.
see the.
Push a bit. Okay, stent boost. I think this is inside the stent. I'm going to go here at 10.
Yeah, 10, 12, 14. The proximal
12.
part can take it. That's for sure. It's 375.
Yeah. Oh.
But I want to make sure that our balloon is capturing the proximal
Yeah.
part of the stent.
Pull back a bit.
Est-ce qu'on peut avoir le clear stent, s'il vous plaît?
Stent boost. Ouais, clear stent.
On se centre, s'il vous plaît. C'est bon.
Ciné.
I prefer to be careful and make sure we're well positioned.
Ciné.
That looks very good. I think we can go there. I don't know if you can see the image of the stent boost.
I'm always surprised, how much we tend to underexpand our stents without imaging.
Yeah.
This vessel, I would hardly have said that we're taking the stent to 375, but now I can confidently do so. Based on the imaging.
And that's probably one reason
Stent
why
boost.
IVUS improves the outcome at some point. If you undersize the stent,
Stent boost again.
or if you don't give nitro and the
back.
vessel is not the real size and you undersize your stent. So under deployment, undersizing would create some more events.
Ciné.
So I think without creating more injury or being really grossly oversized, I think this patient has a 3.75 circumflex. And going with a smaller stent, I think would create more restenosis and more event.
Okay.
That's good.
Wait 4 seconds and remove your balloon.
Move, and then
let's IVUS again.
Yeah, sure, we can do that.
Yeah.
Okay, for the guiding. Move that, and we'll do IVUS. So by doing IVUS also, we won't do contrast injection. So we'll do the IVUS. Then if it's good, we could pull our wire and do our angiogram.
And do the LED.
And do the
imaging in the LED.
Absolutely, yeah. So it's kind of using the imaging to get the most benefit before putting the stent for the size and the length. And now we're checking to make sure it's fully opposed. And then we're also going to use it in the LED, and we'll explain for you why we're doing that after having done the IFR. I'll let Dr. Avram explain that to you. Now we want to do the IVUS.
So, JF,
Yeah.
This patient had accelerating stable angina symptoms. So theoretically, it fits a bit in the acute coronary syndrome compartment, but at the same time, the troponins were negative and the symptoms were progressing over a couple months.
Yeah.
So it could just be stable angina that's cyclical in nature.
Yeah.
How do you put the IFR or, FFR in the context of FAME Courage studies when we know the results of the schema trial, which did not use FFR or IFR in the majority of cases and found no benefits other than a reduction in the use of anti-angina medications?
Yeah, I think that's a very good question, Robert, because at some point we think we're doing the best, angioplasty with just the angiogram, but now we know that physiology is important and IVUS or imaging, OCT IVUS, is important to improve the outcome. So I think the ischemia trial obviously is the data, is a trial, but was angioplasty optimal? The usage of, again, imaging in IFR was minimal. So at some point, I think we need not necessarily to redo the study, but to kind of consider that in our day-to-day practice. And at some point, if we have the funding, if we could do another trial, specifically in diabetic. He's not diabetic. But before that, I had a case that was diabetic, had LAD, and we did the IFR, the pullback, and it was quite interesting to see that the lesion that he had. So he has a severe aortic stenosis. So it's another case. I'm not going to talk too much about it, but it's very useful, I would say, in day-to-day practice. I'm not using it in every cases though. But in this specific case, you'll see the LAD. I think it will bring interesting discussion.
No, because
we'll just do the IVUS for now and the stent that we expanded with a 3.75 up to 14 atmosphere. Huh?
Yeah. We're pretty distal now with our.
I'll flush everything there.
IFR. with the IVUS. Yeah, we can
Okay,
flush.
I hope you see the IVUS image. We're distal to the stent. I'm flushing.
Very distal. Gonna do the pullback, make sure we got a good result. So I think this patient doesn't fit necessarily in the inclusion criteria of the
No.
Renovate PCI trial,
No.
which has shown superior results for image-based
Yes, exactly.
PCI over angiographically based PCI. However, we like to use imaging here in the majority of our cases.
Look at the nice stent position now.
You can see the stent is well expanded. It's round. Gap position, maybe there's a bit missing, half
I think for now it's very nice in my opinion. Do we see the IVUS image at the midstream? I need to make sure that we see the IVUS. So I think the stent overall is pretty round, pretty symmetric, well opposed.
But this is where we took the stent to 3.75.
3.75, yeah.
And we can see here that the stent is well expanded, well opposed. There's some struts, there, and then there's no more stent here.
Yeah, I think we're out of the stent.
Okay.
I think it was because it was beating, the heart was beating, and then you could see the IVUS moving.
Can we play the IVUS again?
So that was distal. Now the branch we saw, the marginal, obtus marginal. Now we're going to get into the stent in a few seconds. Yeah, that's good.
Yeah, I think overall the stent is well expanded, well opposed. I draw what I said. It looks well opposed to the vessel wall, both distally and proximally. There's no distal edge dissection. So this is a well-sized stent. Let's just do one image without with the wire. Absolutely. And then let's go address the LED.
Yeah.
So it will be interesting to see what the audience thinks about the LED and the diagonal. For sure, our plan is to do IFR, maybe some imaging. But in this patient with angina, how would you address that LED based on the IFR?
Exactly. So I'm ready for an angiogram if you're ready to inject. Let's do that. And I think I would pull wire, take 2 views, and keep the wire and the.
I think we can take only 1 view just because we use
IVUS. Exactly. Yeah. No, I think that's way to work. I mean, obviously, it's not the case. He has no renal failure. Like I said, the labs were unremarkable. But if you had to reduce the amount of IVUS, the amount of dye, IVUS can be quite useful.
All right. So great result here. So
put the
1040. So let's put the IFR co-registration in the LED.
Yeah.
We already performed co-registration with IFR in the LED. Jen?
Est-ce qu'on peut retrouver la co-registration de l'IVA, s'il vous plaît? La montrer. On va se placer, nous autres. Phéloscopie, on va se placer.
Tu peux faire avec la table. Ça te montre en haut le roadmap. When it becomes red, you're good.
Ouais, le roadmap, c'est utile. C'est bon.
Okay, so we performed here.
You had like that. Look at the circle. That's the one that we showed before.
So you can see here, it's actually interesting. Can you show back the circle?
Yeah, just to show the difference.
The difference. You can see all the dots here are located around the focal lesion. And now in the LED, we visually see on angiogram lesion that looks intermediate in the midsection.
So is the LED now? Thank you for
the
the LED.
So we see exactly where the cursor is. We see an intermediate lesion. However, when we look at the IFR pullback, the IFR is positive distally at 0.89, although it's borderline positive.
Yeah.
However, on pullback, you can see that there is a gradual increase. So instead of all the dots clustering around the lesion, they actually are spread evenly around. And you can see that the IFR is slowly improving and goes actually 0.95 where we see the focal lesion and normalizes prior to the diagonal. So in this case, we treated the most severe lesion and the IFR is positive, but the phenotype here of the IFR suggests diffuse disease because of the gradual increase on IFR pullback. And visually, you can detect that with this system because the dots that suggest that IFR increase are spread evenly rather than clustering around the lesion.
And we repeated it twice, because
we
were not sure.
To be sure.
We did calibration, nitro.
The other vessel that we should see is the diagonal.
Look there.
The diagonal also has a 50% lesion. We also observed a similar result. Can you show the diagonal? Previous.
Did we get the diagonal FFR?
Maybe we didn't get the diagonal. We didn't save it. Okay. Well, the diagonal, we had a negative IFR, actually of 0.94. And there was also gradually increasing the IFR. So in these circumstances, I think a patient like this one that has accelerating angina, we treated the most severe lesion. We did the state-of-the-art PCI using intravascular imaging. We also looked at the LAD and it suggests diffuse disease. I think here the only indication to maybe do something more would be if the minimal lumen area would be under 4 millimeters square.
Yeah.
So I think just to be clear, it would be worth like assessing the mid LAD, proximal LAD with the IVUS because we have it.
Yeah.
Yeah.
So we have the IVUS. We know the data of the prospect trial. I mean, obviously it's several years ago, but it was a landmark trial where at some point, if the MLA is less than 4 millimeters square, plus if there's more plaque, I mean, again, we'll see with IVUS. We haven't done the IVUS and the LAD yet. We've done the IFR. But I think it's a combination, again, of physiology and imagery, and also, obviously, plaque vulnerability. But he's going to be treated by statin. LDL will be low. We'll give him full medical treatment. But at the same time, let's go through the IVUS because I think... Peux-tu... Qu'est-ce que tu veux? L'aiguille mousse? Go ahead.
15-25.
So we'll go put our wire. Our wire came back. We used it in the endoscopy. So again, let's discuss about is it going to change our treatment? So obviously I'm trying to say, well, do we have data that suggests? So the data we have is that the MLA is less than 4 millimeter. Maybe we shouldn't consider putting a stent. But if the LAD is more than 4 millimeter,
Tanya, roadmap
square,
proximity.
we'll probably treat him aggressively medically. That's what I was saying.
You're not aligned.
And the diagonal, I'm very impressed because I thought the IFR would be positive. Well, we've done it twice with nitro and it's negative. So sometimes what we see the angiogram is not exactly the physiology, as you know. And that's probably how I explained some of the trial, like the ischemia, like the courage trial, that at some point, even there was great people doing the trials and interventionalists, obviously our way of assessing may not have been optimal at the time. But nowadays, we know with IVUS, OCT, with IFR, QFR, all these technologies, I believe it improves the prognosis of our patient. And there's some data. I mean, obviously, we're not talking like just a perception. I mean, there's some data suggesting that, again, imaging will improve the outcome of PCI.
You're in the diagonal.
Now it's diagonal. Okay, so we'll put our wire in the LAD. We'll go do IVUS. You see the lesion, you'll see it. We'll take a shot to yeah, okay, that's good. Excellent, bravo.
No, pull back, doing a septum.
Okay. We have enough to do the IVUS, I think.
Yeah. So I think, in this gentleman, I think we addressed the culprit for the symptoms. Well, obviously, because he's refractory to medical therapy, we want to make sure that we revascularize all the lesions that could be causing ischemia. Obviously, if there is diffuse disease here, as the IFR suggests, medical therapy is warranted. But I think it would be interesting to see that mid lesion. Yeah. What's the MLA? I think that's my remaining question.
And the plaque burden. Obviously, the MLA and the plaque burden. Again, it's a patient with negative troponin, with really angina that was typical, increasing in severity, but not an non-STEMI. And again, he was on minimal treatment before, but now we'll be on high statin, and again, his LDL will be less than 1.8, but we have to say in milligram, so less than 80 milligram or so, or more in the international unit.
Okay.
Let's go.
Yeah, it's good like that. Pull back a bit, actually. You're very distal.
Okay, so we need to advance the IVUS in the...
okay, attends.
Here, let's start it. Okay. We could.
Okay.
We'll flush the catheter. We could also give nitro. We have nitro.
Live image.
Nitro, merci.
Can we start a new run on the IVUS?
Yeah, we'll start a new run. Oui, on est branché.
faut partir une nouvelle run sur la console.
Could we have a new run of IVUS, please, so we can kind of do the measurements? We'll need to do the measurements also.
Ouais,
IVUS.
faut juste parler. Mais il marche pas l'image.
Ça, c'est-tu débranché? Y a-t-il quelque chose? Okay. Sorry for that technical, we'll edit that. But,
Go in live record. Top. Okay. Beautiful. Okay.
Excellent. So you did nitro, you did flush the catheter, and do we have an image?
Oh,
Okay, now we see it. Okay. So we're in the LAD.
Okay, we're going to do the pullback for the IVUS.
We're starting the pullback now. Yeah.
Just do a cine.
Just to see where we are. Well, you can see there. We have to measure there. Look at that there. That's at the lesion.
That's exactly.
Yeah.
That's exactly at the lesion.
That was more severe at the place we see angiographically. Again, that's still something to learn about the physiology and the imaging, the anatomy. Now our eye saw the lesion angiographically. Now we see it by IVUS. Do we keep ourselves from putting a stent, or do we put a stent there? So we'll have to discuss that.
See, I think that's the other area.
Look at that, the other LAD, yeah.
Yeah.
So that could combine the physiology where it's more diffuse, and there's diffuse disease. But here the lumen looks good. So we'll measure the lumen at that place too. That's big. That's kind of.
There's actually less disease than I was expecting for a diffuse disease phenotype.
So we're getting close to the left main now, I think.
Left main.
So do you want to go back down at the most severe lesion, or we have enough to measure that?
Can you
show us that?
measure? This more distal though. Yeah, there's an area that's really tight. More distal, much more distal.
Début là.
Ouais. Okay, you see?
Okay, let's come back.
So here distally.
You see the plaque burden that you have too?
So there's a lot of plaque in that area, and we can see that the MLA is under 4 for vessel diameter that suggests here 10. I'm not sure I would believe the 3.7 by 3.75 diameter, but plaque burden here is quite significant.
Yeah.
And in the first bookmarked section, the other one. Here, can you expand the circle horizontally?
See.
On the right side.
There's
the right side there is
you
missing.
You can see also at the bottom.
Yeah, and a bit at the bottom too. Bottom left. So here the MLA is actually significant, non-significant at 10.
No, this is not significant.
This is really good. So the lesion we actually see angiographically is not severe, but more distally, after the diagonal, there is a lesion, at least by MLA, that is severe, and the IFR there is borderline. So I think here, like the options we have is either to try medical therapy. If the patient comes back, we know we have a target. At the same time, we could also put a short stent because we're there. We have the lesion and do an IFR after to see how we improve the IFR. And at that point, that has more chances of reducing his symptoms. I don't feel strongly either way. What would you suggest?
I'm thinking about it. I would do another angiogram just to see what we have there.
Let's do an angiogram.
Now that we've done the IVUS, to see if we have
maybe 1 cc nitro.
1 cc nitro. To see, because obviously if we don't have a good target to put our stent, I don't think we should put a stent. And is that going to change the disease, proximal, distal? We'll need to manage him medically. So maybe that's a good idea to just treat him medically. But that for someone who we like to put stent, we like to see the angiogram with better lumen. It's not easy to. You see, the lesion is not tight; it's not severe.
That's so we're talking about that lesion. That's what we saw on the IVUS. That area in the mid. AD.
But it was less than 4 millimeters square, and there was plaque burden.
There was plaque burden.
So the other way to think about it is just go put a short stent.
I think so.
Post dilate.
So let's see how much is so I would take maybe a 3015 non-compliant balloon.
Yeah, so that's a bit the uncertainty. You see, we're there thinking about what to do.
3050.
But we are reviewing the IVUS now, and
then I'll take a stent. 3018 stent.
3018. just focus to
But
that
first, let's
lesion.
pre-dilate
I
and see
agree.
how it expands, and then we'll do it.
Again, I would say some people could argue, with ischemia, like we discussed, medical management, huh? But at the same time, we did physiology that's borderline. We did the IVUS, and we have that lesion. I think we put a stent. I discussed with the patient before and the options and how many stents we're going to place. I thought we would do more stent, but now I think it's focal stent. So that's another thing about the IVUS. We don't put unnecessary long stent. Yeah. So we'll try that, and we have the wire for the IFR, so we could do it after.
We'll do IFR after.
We do IVUS after. We could do all of that.
We'll do IFR.
Excellent. I'll go see how the patient is doing. Monsieur, ça va bien? Nous, ça va numéro 1. Probablement que ça va être 2 stents qu'on a à mettre. On a mis déjà un, ça a bien été. C'est là que vous avez eu des douleurs. Puis là, on s'en va faire l'autre qu'on a fait l'imagerie dedans. On voit une lésion, puis on pense que c'est mieux de mettre un stent pour que vous ne revenez pas nous voir trop souvent. OK? On va faire ça de même.
Hors sirop, non? Resolute, c'est correct.
Oui, c'est bon.
So, in the FAME and in the FAME trial, FAME 1, FAME 2, patients that had a positive IFR and had angioplasty had fewer recurrence of MIs.
Yeah, sure.
In ischemia, however, there was an increase in patients that had angioplasty of periprocedural MI, but we also saw a trend, after 1 year, 3 years of reduction in MIs. However, the increase in periprocedural MI was so high that it would offset the benefits.
Yeah. Overall. But long term, when you followed up the ischemia trial, there was a benefit when you were able to rationalize the patients,
Yes. Look at the roadmap.
The roadmap.
I think you
may not see it, but we have the roadmap in this new room, Philip, new room.
Okay. Pull back.
Ouais, c'est ça. T'as bien, là?
Non, pas trop. Test.
Okay, good. So we use a short.
Perfect. So we're here. I'm at 20 atmospheres with a 3.0 12 balloon. So I'm around 3.4.
Yeah.
Is this a compliant balloon?
Semi-compliant.
Semi-compliant.
But at the same time, these balloons, I always say what you see on the chart there, it's done in air. So at some point in a vessel, let's say calcified vessel or whatever, there's resistance. So you don't always have exactly that size. So we have to appreciate that at some point. All these measurements are not really done in vessels. They're done in air. But it's useful to kind of follow that to give an idea. Okay, we'll be ready with the stent after. And then we can do IVUS if we want, or we can
or IFR. Euro. Your wire keeps moving. I have to be more careful.
Okay,
we'll take
go with
the
the stent.
stent.
So again, 3018 resolute.
Whoa.
Qu'est-ce qui est arrivé?
I think it's, yeah.
Ouais.
I think the stent is contaminated.
Let's just take another stent, please.
Remove it.
On peut-tu avoir un autre stent 3018, s'il vous plaît?
So this stent, I'm sorry, I contaminated stent. Obviously, this is something that can happen. So we're
less than 1% of our case. Less than 1%.
Oh, less than 1 in 1,000, I would say.
Yeah, exactly.
Less than 1 in 1,000. But we will take a new stent and we'll plan and we'll just do the post PCI IFR. I think it will be interesting to see how much we were able to improve by tackling the most focal
Me too.
lesion.
I'm curious about that.
It was good. Like here, we can see angiographically, the lesion was completely open, even with a semi-compliant balloon. 2000 en périphérie.
2000. Yeah, perfect. Okay, so 3018, like we discussed before, for the thin strut. It should do a very good result. Now, do we have any questions, Sophie, on Slido? Okay.
I don't hear anything.
You don't hear anything, hein? Ben moi, j'ai entendu de l'autre côté.
Ah, okay.
Merci. Okay. And please let us know. We're going to be done here in probably 5 minutes. And then if they want to go in the other room or if it's done completely, we can continue until 4. Okay, we'll do the stent.
For the Orsiro.
Yeah, it's nice.
What
color.
is it made of?
Well, it's cobalt chromium, but
Chromium.
it's the coverage and coverage of the
Beautiful.
stent. And it's a degradable polymer and it's sirolimus. It's been now used now for more than 10 years, but the data comes out
Recently.
very positive. So
Very positive, especially in STEMI patients.
yeah, exactly.
Especially in STEMI patients. So it looks, the stent is beautiful.
And it's
It looks-
low profile.
Very low profile, very thin struts. Maybe not the best for highly calcified lesions, but
Yeah,
in
it hasn't
plaque
been
rupture
studied.
and everything,
Yeah,
I think it's a good stent. If you want to recross for bifurcation, I think it's also a very good stent.
very flexible.
Very
You
flexible.
can recross for side branch.
Very good profile.
I think it's
I think it's our fellow's
value added.
favorite stent.
so we'll go deploy the stent in the middle. Measure the IFR. Good. And then we may finish with the IVUS because no one spoke to me about if we're going back to room 2 or if we're staying here until 4
Staying
o'clock.
here until the end.
No, we can continue until 4 o'clock.
We're having a great time.
Yeah.
Doing physiology and imaging based PCI. Again, not the most complicated case technically. However, very interesting for discussion and potentially life-changing for the patient.
Yeah.
Pull back a
Okay,
bit.
okay, let's do a cine just to make sure.
Cine?
Okay, wait, cine. I like to make sure we put it at
Pull
the
back.
a little bit, not much, not to the diagonal. Okay, no more. No, be careful of the
Cine?
diagonal. Whoa, it's moving a lot. So we have to make sure our guiding is stable, the stent is stable. Okay, are you okay, Rabbi, with
Yeah,
that?
Cine?
I can do your okay, you got it.
It's okay.
You see, that's kind of I mean, it's a simple trick, but at some point when the stent moves like that, you have to make sure that your guiding is
I'm at
well
18.
intubated in the left main because, or else you have the guiding moving, you have the balloon
Off.
stent moving.
20.
And I've seen cases where the stent
thought
was
that
misplaced at
doesn't
some
apply.
point. So it's not frequent, but I would say I'm very precautious about putting the stent, as all of us are. But sometimes we want to be quick. And if we're too quick, we can have some stent, not placed at the right place.
Yeah.
So I'm very careful. I take the time. And if I'm not sure, I wait, position the guiding, tell the patient not to breathe. That's another trick sometimes. But the heart is still beating. So we have to make sure we understand the movement. Okay, so we're going to remove that. Give some nitro. Do our IFR, I guess. And probably finalize with the IVUS. That's the plan. Huh, Rabbi?
Yeah.
Make sense?
Yeah.
Okay. So this.
No, yeah, we already gave.
Yeah, we did ACTs over the procedure to make sure we had around
Nitro.
250. It's correct?
Yeah, just. Cine?
We do the cine. Oops, our guiding. You see what I told? The guiding is not fully intubated. That's why, one reason why you had the movement. Okay, well, I'm ready.
Cine?
That's better, much better.
Oh, there is something going on more distally.
Well, I
So-
think our stent.
Maybe moved a
Yeah.
bit. Can we have 500 cc bolus?
Let's see avant, and we can still give nitro to make sure that it's not spasm distal to the stent. But est-ce qu'on peut voir la lésion avant, s'il vous plaît?
Le 10-40, le premier 10-40. I think
Maybe
we
it's
stand
a
the lesion.
spasm.
Maybe spasm or there is a dissection.
We'll see. We'll do the IVUS. But okay, the lesion was much proximal, so your position
We're
is
good.
good.
Position is good.
So either we give more nitro, wait a little bit to avoid putting a second stent distal. We went with a trio. So is the distal vessel trio? I don't think so. The guiding is 6 French, 2 millimeter. Maybe it's 2.5, So I would wait. I would wait a bit and maybe do IVUS also because you're right. It could be dissection. But okay,
Let's
you
see
give
what
nitro?
Let's give some nitro.
Yeah, you gave us some?
No.
No, we'll give more nitro, 1 cc, and then we'll do another shot to see if it's spasm.
Test.
J'avance à nitro.
Ouais.
On peut donner un flush au patient 300
Ouais,
cc, s'il vous plaît.
Cine.
Ouais, ready. Maybe
Looks
a
a
little
bit
bit better.
spastic.
Should we do the IFR while we wait, then
I
the
think
IVUS,
so.
and we see? Because
Okay,
at some point,
draw black.
do you want a dry
Flush.
Yeah.
Swing de flush.
OK, flush, une swing de flush. Merci. Super, Tanya. Thank you. Tanya is great. She's watching, helping us, making sure we're okay.
So,
So
with
we'll-
the IFR pullback with this device, sometimes the hardest thing is to put back the wire.
Yeah.
So you have to align the three sensors.
I don't know if we see, but
Yeah, I don't know if you can see, but you have to align them.
align them, and then it's like a whatever a pince. Yeah, that's it. You push and you release.
Can we go IFR, Jen?
So hopefully you'll be able to see the IFR, and then we'll do the
Geneviève, IFR.
co-registration
IFR.
again.
Je me suis reconnecté, je ne sais pas si tu le vois.
Ouais, on va se
Va
mettre en
en
IFR. Okay. We're just waiting to get the
Va dans la table des
IFR.
mots en live. Fais une nouvelle mesure.
comme tantôt. Est-ce que c'est bon?
Non, on voit rien.
Non,
On
on voit
voit
pas,
l'image, on voit Sync Vision, Co-Reg. Un de Néo.
2.
Va, ouais. Okay. Physiologie. Active le mode, ouais.
Bon.
Good.
Excellent. So now
do
now we're let's leave
IFR
it,
spot.
Yeah. So you gave nitro. We have the flush. You flushed.
Pardon?
We could normalize. Did we normalize?
No, we don't need to.
So we should normalize, eh? Because we did not normalize.
Okay.
So all small things that we have to think about. We have to make sure that we normalize.
Go and see if it's.
We're gonna go make sure we normalize. Let's go back more proxy. Okay, that's good. That's pretty good there.
Okay. Normalize. Merci.
Okay.
Normalize again.
Normalize again. Okay, that's one. So that's interesting because we had 105, which is not within the, we like to have a 1 or 0.98 or 102, but it was 1. So we'll go see the measurement, what it looks like now. Yeah, that's good. You see, it was, let's wait.
Oh, just a second.
Let's wait. Okay, now let's position, okay, 0.94, 0.91. You're moving it up the wire. It's maybe too far. Yeah, that looks good. Looks good.
Okay.
Okay, let's measure there, and then we can do the co-registration.
0.91.
0.91.
So it is a bit better. It was 0.89. You know where it started.
A bit.
Another
0.92, 0.91, 0.90.
I'm sure that's the challenge with diffuse disease is that you will not necessarily improve the IFR by stenting.
Exactly. Could we do the co-registration to see if it's similar as we had before, like a pop dot all the way?
Do another IFR spot.
When we're ready, we'll do the pullback.
Okay, 0.91. Let's do the pullback again.
Okay, once we have the blue line.
No, attends.
We just have to wait till we have the blue. Okay, now we can start a slow pullback, slowly and scopy, and then we'll do an angiogram.
Now it's inside the stent. You can see that it actually normalized inside the stent at 0.94. I wonder if there is a drop because of the lesion that we created distally.
Well, we'll see.
Because it's pretty normal.
It's pretty normal now. Yeah, absolutely.
Again, phenotype of diffuse disease.
But it's very diffuse, like we had before. We'll do a cine.
I will do a second stent.
Okay. Yeah, we can do a second stent.
Cine?
Or we could do IVUS.
Yeah.
See, it's less than it was before.
Yeah, less. We can do IVUS too.
Yeah, we could do IVUS. So what we did now, we will see the dots appearing where you have loss of
we have
pressure.
to trace the vessel because you don't see the distal edge. Ouais.
Oui, on l'avait rempli. Okay, so it seems that now we have not been able to get the dot like we had before. There's a message. Yeah.
Fais l'éditeur et trace le vaisseau, Jen. Trace le vaisseau
That's the vessel.
avec A.
So there's way now to recap. Usually it's automatic, but in this case now,
Or
for
this
whatever
one.
reason, we have to redraw the vessel, and then it will integrate the.
Jusqu'à la section
IFR.
distale, Jen. Faut que tu ailles jusqu'en bas.
Okay, that's good.
OK.
Okay.
Terminé.
Now let's see what it looks like now after redrawing the vessel. Aha.
Okay.
You see it. So you see, it's.
0.93 distal.
I would leave it like that
I
personally.
think so.
Yeah.
Let's do IVUS and causation.
Let's
I
go do
think
the IVUS.
the IFR is a bit better. The lesion, we no longer see it angiographically. You know, should I put a stent or not? I'm not sure
Well, I
still.
would, in this
but,
case, I would probably not put one. I
Yeah.
would leave it instead of doing overlap stent. I mean, if I need, I would do one, but let's go see the IVUS. It may change my idea, but I think some of it could be spasm because we kind of went generously on the stent.
Very big stent. Yeah.
Went with pressure. And I think the vessel distal was more 2.5. Okay, j'ai le wire. So we will reflush the IVUS, obviously. Tu as le wire. I'm going to reflush the IVUS wants to be really flushed generously. You have good images. And this is high definition Opticross Boston Scientific, which is, gives us really beautiful image. I think you saw in the other cases some OCT that are great too. But this one, the wire, we'll put back the wire down. These things happen. That's okay. We'll put back the wire.
It's because we did pull back. So our fellow is always in control of the wire. No, you're in a septal. Use the roadmap. You're not looking at the right thing.
Yeah. Now we have the roadmap. So what from Philips that we know? Are we in the LED now? Yeah. Okay, good. So
you're in a septal.
Are you in a septal or?
Septal.
You're in septal.
100% sure.
So you see it guides us. Again, without giving contrast, we see where to advance our wire with that roadmap. And we're clearly in the septal. Now we're in the LAD, I think. Maybe again, a septal.
Let me see.
Go slowly. That's okay. I mean, it's kind of
okay.
Okay, we'll leave it there. We go to the IVUS. Monsieur, c'est presque fini. Ça va très bien. De notre côté, là, on a la job de finition. It's the finishing touch. Hein, Robert?
The finishing touch. This still, you're going to be in the stent. The radiopaque marker is where the probe is. Okay.
Yeah. Okay, super. So flush again. We have
flushing.
Can you see the IVUS? I hope so. On the lower corner. Back. And we're starting to pull back.
So let's see if we need to do more work on this vessel or not.
Well, we have it here.
What do you think? More work or no work?
I think it'll be nice if we don't do anything. Yeah. There's not much disease there, huh? There's not much disease. So that's the other thing. I mean, like I told you, the angiogram yesterday, they gave nitro and the vessel reacted. So I think
our X-ray tech and nurse, they say no more work. Okay. But we'll see. You know, we let the IVUS decide.
There's a plaque there. There's a plaque, but there's still lumen. I think I'm not sure. Yeah, check where you are. Yeah.
Much of disease.
You're about there where we saw. You see the stent.
So you can see here the stent is showing up.
There's a bit of plaque.
Well
expanded. Still to the stent.
Again, I think we went 3.0 at 3.5 millimeter. I think it was the right size.
Yeah.
You can see we expanded very well.
Again.
There's no dissection. That's very important. There's no hematoma.
I like
that. It's well expanded, well opposed. All the way up to 3.5 millimeter. That's what we wanted. Very well done.
I think it's very nice. I think there's disease, obviously, distal to the stent. That may explain
as well. I think we're done. I will remove the wire.
Done. I agree.
I will remove everything, do a final angio, and call it a day or a night, depending where you're listening.
Call it a case. Congratulations, everyone. Thank you very much. I hope this was an interesting case of combining physiology with imagery. So imaging, I think we were able to do it with only 2 stents. The patient, one of the objectives we had on the slide that you did not show, was also to discuss antiplatelet therapy.
You're not-
We'll give
can you be
nitro
more
there.
selective?
We'll give nitro.
We're non-selective. That's
not
why.
selective, but we'll
There is
give nitro again.
Really?
So the duration, obviously, is a stable patient. So minimum 6 months. I think he's not high risk bleeding. He has no other anticoagulation. I think for now we're done for this.
The flow is a bit slow.
I agree. I agree. Sometimes maybe. Avez-vous des douleurs, monsieur?
Avez-vous des douleurs? Combien sur 10?
Pain, you pulled the wire. We'll wait a bit. We'll wait a
Trois
bit.
sur 10.
Obviously, we were there.
Let's
quite
do
a long
some
time.
adenosine.
Maybe you should do that.
Enfin,
Est-ce qu'on peut avoir de l'adenosine, s'il vous plaît?
We will be changing rooms.
Perfect. Merci, Danny. So again, thank you very much. We'll continue and finish this case.
adenosine, verapamil.